So today I'm going to talk about prolonged labor, okay, in the first half of the class. Now let me revise a little bit. Let me give you the concept of labor once again, then it is very easy for you to understand. Now, labor is a process, isn't it? It's a process and it has got a different stages. There are 4 stages of the labor. Please unmute yourself. There are 4 stages of the labor. First stage, second stage, third stage, and fourth stage. I'm not going to ask this question because I hope every student know this already. First stage starts from true labor pain. When the true labor pain occurs, then we believe the first stage of the labor has started till the full dilation of the cervix up to 10 centimeter. That is first stage. In second stage of the labor, from the full dilatation of the cervix till the baby is delivered. That is second stage. Third stage, placenta and membranes are delivered in third stage. And fourth stage is not exactly a stage, but it is an observation we do 1 hour, okay, till 1 hour after the labor. So these are the four stages. Now, what is prolonged labor then? It is very easy now. Any of those stages, okay, especially first, second, and third, can be prolonged. There is a certain duration for each of those stages. If the duration is longer than expected, it is called as prolonged labor. Now, let's move further. See here, it is defined as when the duration of any stage or phase of the labor is prolonged than expected, and it can happen to any stages of labor. First stage, second stage, or third stage. Now, let's discuss about what happens in prolonged latent phase of first stage of the labor. Now, we all know first stage of labor is again divided into 2 phases, latent phase and active phase. Now, according to the diagnosis or definition of latent phase, the cervical dilation is still less than 3 centimeters. If it is more than 3 to 4 centimeter, it moves on to the active phase. Please do not forget that. So the number 1 criteria for prolonged latent phase of first stage has to be cervical dilation remains less than 3 centimeters. And another important point is duration. Look at the duration now. More than 20 hours in primigravida or primipara, and more than 14 hours in multipara. We all know in multipara the duration is shorter. The expected duration is shorter. That's why just more than 14 hours would be enough for the diagnosis of prolonged latent phase of first stage of the labor in multipara. Whereas in primipara, we need that duration for more than 20 hours. Okay, so please do not forget that. So let me highlight this for you, underline. Okay, this is important point. Now, what are the causes of prolonged latent phase of first stage? The most common is injudicious use of analgesia. Okay, injudicious use of analgesia means the analgesia was not really required, but still, okay, it has been given, and that analgesia is causing a prolonged latent phase. The important analgesia which you use is pethidine. Okay, pethidine. So just think about injudicious use of pethidine. Another is hypotonic contraction. Now, what do you mean by hypotonic contraction? What do you mean by that? Yes.
Last
The
contraction
of the uterus cervix, which does not have the intensity to fulfill that, sir. That
less tone of muscles.
Okay. Now you all are correct. The meaning is very easy. Hypotonic contraction means the contraction is not that intense. It is not that powerful. The labor pain or the uterine contraction should be powerful enough, and then the contraction should go on increasing in intensity. The next contraction should be more intense than first. The third is more intense than the second. This is the hallmark of a labor pain. But if those contractions are hypotonic, like inadequate frequency, duration, or intensity, then also there will be prolonged phase of the labor, definitely. Now, another is hypertonic, okay, high intensity but inadequate duration, short duration, okay, vigorous type of contraction is occurring but very short duration, that is also not enough. So these are some of the important causes. And regarding the management, we have to give enough rest, okay, and give a bit of sedation with narcotics or sedatives. This narcotic is not that preferred here, because this narcotic itself may be causing a bit of prolonged stage. So probably benzodiazepine type of drugs may be preferred. Let's move on. Now, what is another phase of first stage of the labor? That is active phase. You all know active phase means after the cervix is dilated by 3 centimeter, more than that, or after that, the active phase of first stage starts. So regarding the diagnosis, that has to be the first criteria, isn't it? See here. Quite easy. That's the first criteria for us. So cervical dilation should be more than 3 centimeter. And then the acceleration phase of dilation has been reached. This is what we talk about. After 3 centimeter is reached, we call that the acceleration phase. And prolongation is diagnosed if cervical dilation is less than 1.2 centimeter per hour in primipara, or less than 1.5 centimeter per hour in a multipara. It should happen more than this in a normal case. But if it is happening, a bit delayed one, like it is not happening as expected, then this is called prolonged or arrested active phase of the labor. Arrest is diagnosed if cervical dilation has not changed for over 2 hours. Now, this is diagnosed by per vaginal examination. Per vaginal examination, isn't it? We keep on doing that during the stages of labor. That's how we diagnose how many centimeters the cervix has dilated. What is the effacement of the cervix? So the obstetrician have found that there is no change in the cervical dilation after the lady has entered into the active phase of labor for 2 hours. It is known as arrest. It is known as arrest. Okay. Now, see this. Now, what are the causes? What are the causes of prolonged or arrested active phase of the first stage? It is very clearly written there. Abnormalities of the passenger. Passenger means fetus, okay, which is coming down, passenger. If the fetal size is excessive, big size fetus, or if there is abnormal fetal orientation in the uterus, then the arrest occurs, or prolonged second phase of the labor occurs. I should say the prolonged active phase of the labor. Okay, we are still in the first stage. Now, let me ask you one question. What is the average fetal size at the time of birth? What is the normal, size of the baby?
35 centimeters.
Okay, so he's answering, in a centimeter measurement. Okay, fine. Now, I cannot ignore your answer, okay, because the question was a bit vague. So, according to the weight, what is the normal weight of the baby at the time of birth? According to the weight. Yes?
3 kg.
2.5 kg.
Exactly. The answer is, it varies. You can give a range here. Okay, you can give a range. Average.
4.5.
Exactly. It starts from 2.5 kg till 4 kg. That is a big range. 2.5 kg to 4 kg. But let's talk about the average one. The average is around 3 kg all over the world. But more than 2.5 kg is considered fine. There's no problem. Less than 2.5 kg is known as low birth weight baby. Now, it is a problematic baby. Another one, if the head of the baby is big. Now, somebody is answering about that the head size is 35 centimeter. The circumference of the head, okay, I'm talking about, remember, the circumference of the head is 35 centimeter, but biparietal diameter is 10 centimeter. So these are the different things here. So if there is hydrocephalus, when the baby is developed inside the uterus, that big head cannot come out. If there is cystic hygroma, in the surgery you have studied cystic hygroma, there is a big mass around the neck, the baby cannot descend downwards. So these are some other points. So some problem with the passenger. And another thing, what is the normal fetal orientation in the uterus? So this is a bit of a difficult question probably for you. Please pay attention. The fetus should lie longitudinally. This is called longitudinal lie, and head should come down first. So cephalic presentation, longitudinal lie and cephalic presentation. And then if we consider in that head, occipito-anterior is the normal fetal orientation. Occipito-anterior. If occiput transverse is there, if occiput posterior is there, okay, then it is known as abnormal orientation. Now let's move on. Another is called abnormalities of the pelvis, the bony pelvis size. Question is, what is diagonal conjugate and what is a normal diagonal conjugate? Maybe somebody has still remember that. Yes?
10.5 centimeter.
Okay, Irfan, what is that first? How do we measure that diagonal conjugate? I want to listen to that answer. Yes?
So diagonal conjugate, sir, it is from the symphysis, sir, from the pubic arch to the symphysis of the sacral promontory, sir.
Okay, okay, good. So what is the normal diameter? What is the measurement of diagonal conjugate?
Sir, 10.5 centimeters.
It should be more than that.
Centimeter.
It is
12.5, sir.
okay. So maybe different books may be giving a little bit different value. It may be here and there by 0.5 centimeter, okay, but not more than that. It is usually around 11.5 centimeter, 11.5 centimeter, okay, or more than that. Now listen properly. If that diagonal conjugate is less, that means the overall size of the pelvic inlet would be less. Now, if that happens, then the baby cannot descend downward. So there will be arrest in the active phase of first stage of the labor. This is known as cephalopelvic disproportion. Cephalopelvic disproportion. According to that size of the head, the pelvis size is smaller. I'll talk about that so many times in the subsequent classes. Abnormalities of the power. Now, power is a uterine contraction. If it is dysfunctional or inadequate, then also there will be prolonged or arrested active phase. Now, let's move on. Let's talk about how to manage this type of situation. See that. Okay, how to manage it. Regarding the management, this is directed at assessment of uterine contraction quality first, whether it is hypotonic or hypertonic. That's the first thing. Second, what is the duration? Duration is really important regarding the uterine contraction. Now see this. Contraction should occur every 2 to 3 minutes. It should last 45 to 60 seconds with 50 millimeter of mercury intensity. So this is a bit of theoretical discussion actually. See this, every 2 to 3 minutes, last 45 to 60 seconds each of the contraction, and each of the power of that contraction is 50 millimeter of mercury intensity. Now this intensity is not usually measured, okay, it's just a theoretical, that's what I'm saying. But this frequency of the contraction and how long they last, we can really measure it or we can count it. These are the adequate type of contraction. If it is not happening, then prolonged first stage of the labor occurs. If contractions are hypotonic, you have to stimulate the uterus by giving one of the important drug, which is known as oxytocin. So every student know how oxytocin act. Let me ask you, from where oxytocin is released in our body? Where?
On the
Interior.
posterior pituitary.
Is it
Posterior pituitary.
is it anterior or posterior? It's always posterior, okay? It's posterior, not anterior. Posterior pituitary. Prolactin from the anterior pituitary, oxytocin from the posterior. Never get confused. But actually, oxytocin is, stored in the posterior pituitary. It is released by hypothalamus. Hypothalamus secrete or release oxytocin. It is stored in a posterior pituitary. When the proper stimulation reaches there, then it is released from there. So that is a very nice answer if we say like that. But during pregnancy, we don't rely on that oxytocin only. We have to give oxytocin from outside with the help of IV drip. So this has to be done, and it is routinely done all over the world. If contractions are hypertonic now, give morphine sedation. They are too powerful contractions, but probably the duration is not enough. So during that time, we need to calm the lady. And the pain is also excessive there because of hypertonic contraction, so a bit of analgesia is necessary. If contractions are adequate, what you need to do now, proceed to emergency cesarean section because the arrest has already occurred. See this? We are talking about prolonged first stage of labor, either prolonged or arrest. So when the contractions are adequate, but still the labor is not progressing, there's something wrong either with passenger, okay, or either with passage or either with force or power. So during that time, cesarean section may be necessary. And I'm sure everybody knows what is cesarean section, isn't it? What is cesarean section?
Surgical.
You can say this is
Surgical apparatus for delivery.
Surgical delivery of baby through incision in the mother's abdominal uterus area.
Exactly. You can simply say it is a surgery which is done, okay, to take the baby out from the uterus. Surgery done to take the baby from the uterus, and we give that incision in the anterior abdominal wall. We'll talk about cesarean section. This is an important class, okay, later on when we enter into the obstetrics procedures or surgery in obstetrics. We'll talk about cesarean section. Let's move on. Now, all of you, please pay attention here. This is a very good summary of the thing which we have discussed till now. Okay, this is a summarized version. These are the phases of the labor. Okay, the first stage, latent, and the active one. So latent phase when the dilation of the cervix is less than 3 centimeter, active when it is more than 4 centimeter, or you can say it is more than 3 centimeter also. It's the same thing. If latent phase is prolonged, okay, this is how we diagnose it. This is the criteria. In primary gravidae less than 20 hours, in multigravidae less than 14 hours, 13 to 14 hours, okay? We don't need to be very precise there. How would the management now? Ambulation and sedation. Okay. A bit of ambulation here and there in the labor room may help. And if this is a bit of hypertonic or powerful type of contraction, then sedation may help. Regarding the prolonged active phase, see this, in multipara, okay, if the progression is less than 1.5 centimeter per hour, and in primipara or gravida, if it is less than 1.2 centimeter per hour, then the criteria is met. Okay, the criteria is met if it is less than this, and we consider 3 P's here to find out the cause why this active phase is prolonged or arrested. Probably some problem regarding the pelvis, maybe it is inadequate or small in size, either in the inlet, either in the pelvic cavity, or in the pelvic outlet. Anywhere there may be a problem. It may have problem regarding the passenger. The baby is big size, the head is also big, there is some other masses around the neck of the baby, okay, or the orientation of the baby is not proper. And third thing is power. Uterine hypotonia, uterine atonia, isn't it? Even hypertonic contraction, but inadequate one. So all these are important ones. Now, arrest of the active, if there is no progress for the 2 to 3 hours, this is called arrest of the active phase of first stage of the labor. We need to do something. Adequate power is diagnosed by frequency, duration, and intensity. Already talked about this. Now, regarding the management, if there is adequate contraction of the uterus, but still there is prolongation of the labor, straight away take the lady for cesarean section. Okay, cesarean section is done. But if the adequate powers are not there, means there is uterine hypotonia, you have to give oxytocin, IV oxytocin, to stimulate the contraction of the uterus. And in some other time, you can also go for artificial rupture of membrane, AROM, okay? Artificial rupture of membrane. Now, let me talk a little bit about this. Sometimes the lady come to the hospital without rupture of the amniotic membrane, means there is no leakage of the amniotic fluid. So the obstetrician will rupture the membrane from their own side with the help of a forceps. Now it will help in the progress of the labor. It is a good thing. When the labor is not progressing, artificial rupture of the membrane can be done to increase, the progression of the labor. Now, one more information you get from artificial rupture of membrane is what is the color of the amniotic fluid. That information is also important one. And if it is clear, you are quite satisfied. Yes, the baby is fine inside. If the color is a bit green, means meconium has been passed already, then we need to be hurried for the delivery. Now, after IV oxytocin, okay, see this, if the rate of the progression is more than 1.5 in multipara and more than 1.2 in primipara, then you are quite happy. Okay, continue with your conservative management, means wait for the delivery to occur. If still the progression is not like that, then go for cesarean section. So this is a good slide which is telling us regarding the management as well as all the different diagnosis thing. Let's move on. Now, after talking about the first stage of the labor, let's talk about second stage. What is the diagnosis of prolonged second stage of the labor? See there, please. Regarding the diagnosis, if there is failure to deliver the baby in 2 hours in primipara or 1 hour in multipara, this is called prolonged second stage. Okay, 2 hours in primipara, 1 hour in multipara. With epidural analgesia, we know it will be prolonged. So we have to give 1 additional hour regarding the definition. So what does that mean? Let me clarify it. In primipara, if we have given epidural analgesia to relieve the pain, it is given to relieve the labor pain. Okay, if it is excessive, so many of ladies, they want some painkiller, they request for that. So the obstetrician may give this with the help of anesthesiologist, of course. So we have to give additional 1 hour there, like 3 hours in primipara if epidural analgesia is given, and 2 hours in multipara if it is given. Now, one small question. Where is epidural space? Where is that?
In the spinal cord, sir.
Okay, where exactly? Epidural means?
Around the spinal cord.
Okay, epidural means
Space between.
superficial to the dura mater.
Between the
Dura mater.
vertebral wall.
Exactly, between the vertebra and the dura mater. Between the vertebra and the dura mater, because dura is the outermost layer of the meninges, then arachnoid matter, then pia mater comes. So epidural or extradural, it's the same term. That means outside the dura mater there is a cavity or a sac. So we put a needle there and give a lot of analgesic. So this is the meaning. Now, regarding the cause of prolonged second stage, it is same as active phase abnormality. The problem may lie with passenger, that is fetus. The problem may be there with the pelvic cavity, either inlet, either the real pelvic cavity or true pelvic cavity, which is judged by ischial spine, or the pelvic outlet. And the third thing is the power. We already talked about that. Now the important point, how to manage it. If there is prolongation of the second stage, how we manage it. See there, please. Now it involves, assessment of uterine contraction and maternal pushing effort. This is very important if the second stage, if we expect the normal duration of the second stage. Without uterine contraction and maternal pushing effort, the baby cannot be pushed outside. That is impossible. So first assess that, whether it is enough or not. If they are both adequate, if they are both adequate, see this is important. Assess whether the fetal head is engaged or not. Now, you all know the meaning of engagement. I've asked this question so many times in the previous lectures. Engagement means the maximum diameter of the presenting part. Let's talk about fetal head now, has entered into the pelvic cavity, or entered into the pelvic brim. This is known as engagement. Please mute yourself. This is known as engagement. Now, if it is adequate, then we can wait. We can wait and go for the conservative management. For example, use oxytocin to increase the uterine contraction. We can go for that. See here. Or you can stimulate the lady to push further. You can stimulate. You can ask her to give extra effort. You can teach her how to push. All those things can be done. They are important in the second stage of the labor. See there? Now the problem is, if the head is not engaged, proceed to cesarean section. Now, why head is not engaged? What's the problem? Why head is not engaged? Yes? What may have happened there? Again, the answer is the pelvic cavity size is not enough. Either the pelvic inlet size is not enough, or the head is too big. So these are the same answers you can give. So during that time, you don't have any option. Take the lady for cesarean section and take the baby out from the anterior abdominal wall. But if the head is engaged, consider a trial of either obstetric forceps or a vacuum extractor delivery, especially after the engagement. If the station is 0 or lower than that, then we can even think of forceps delivery or vacuum delivery. These are called instrumental delivery. We'll talk about that in the separate class. But remember, they can be applied only after the engagement of the head. Means the head has entered into the pelvic cavity. Now, forceps and vacuum are a complicated type of delivery. So we'll talk about that separately. Now, to summarize, what we do in prolonged second stage. So all of you, please pay attention here. Regarding the diagnosis, failure to deliver the fetus in more than 2 hours without epidural or more than 3 hours with epidural. In a primigravida and multigravida, or primipara or multipara, the duration is a bit different. In multipara, the maximum is 2 hours with epidural, because without epidural more than 1 hour. If we give epidural, it is more than 2 hours in multipara. In primipara, 1 hour more than that. Now, regarding the cause, see this: passenger, either big fetus or abnormal orientation of the fetus. Regarding the pelvis, mother's bony pelvis is inadequate. Maybe the pelvic inlet is smaller, maybe pelvic cavity is smaller, or outlet is having problem. And power, judge the uterine contraction if they are atonic or hypotonic. Atonia, it doesn't usually occur, usually it is hypotonic. Okay. Then you can stimulate that by giving oxytocin, and judge for the pushing effort by the mother. Stimulate her to do that. Now, one important point is only this power is the thing you can change here. If there is problem with passenger and pelvis, straight away you have to go for cesarean section. You cannot continue the conservative management. So the same thing is written here in management. Assess the uterine contraction quality. Okay, if you are quite happy, then you can proceed with conservative management. Oxytocin if hypotonic uterine contraction. If engagement of the head is there, forceps or vacuum extraction can be tried. VE means vacuum extraction. Okay. Otherwise, if any problem, if you believe the baby is not going to deliver soon, there is some serious problem inside, go for the cesarean section. That is always safe. Now, what is the definition of prolonged third stage of the labor? Now, we all know in third stage of the labor, there is delivery of placenta and membrane. So if they fail to deliver within 30 minutes, we call it prolonged third stage of the labor, also known as retained placenta, if it doesn't come out in 30 minutes. What may be the cause? The most important cause is again inadequate uterine contraction. See this, inadequate uterine contraction. Sometimes what happens, if the placenta doesn't separate, in spite of IV oxytocin stimulation of the myometrium, think of abnormal placental implantation inside the myometrium like placenta accreta, placenta increta, and placenta percreta. Now, I'm sure some of the students still remember what are the meaning of this. Yes? Any answer? What is accreta, increta, and percreta? Who can answer this?
Sir, in placenta accreta, there is invading of the invading of the outer inner mucosa, but there is no
into the uterine wall, and sir, it means the myometrium wall, to be simple, sir.
Okay. Yes, yes. Fine. Yes, Uzair, I agree with you. Yes,
and,
yes, Irfan. Yes. What is percreta? Percreta means what?
and sir, percreta, there is a whole myometrium, invasion of whole myometrium.
Exactly. Exactly. Okay. Very easy meaning. So for the sake of all other students, please remember accreta. It is just invaded. Just. Okay. Just invaded. The myometrium is just invaded by the placenta. In creta, it is probably invaded up to the half or even more than half. And percreta, it has invaded the whole thickness of the myometrium. Sometimes it has reached to the serosa as well. So that is percreta. Regarding the management, it may require manual placenta removal or rarely even hysterectomy. Hysterectomy is not usually required, but in case of placenta percreta and increta, sometimes they are very difficult to remove even by the manual removal. Then we need to go for hysterectomy. Otherwise, the lady will bleed heavily and she may suffer from a postpartum hemorrhage. She may die because of that. So sometimes even hysterectomy should be necessary. Okay, so let's move on. Now, let's summarize what is the abnormal third stage and what we are going to do. So, if it is crosses for more than 30 minutes, that means within 30 minutes, if the placenta doesn't come out along with membrane, we call this prolonged third stage of the labor, also known as retained placenta. The commonest abnormality here is a prolonged labor itself. Remember, if the first stage and second stage of the labor are prolonged, the uterine inertia occurs. There is atonicity of the uterus occurs. The contraction are not proper, and without proper contraction, bleeding keep on happening, and then placenta is not separated. Okay, the same thing is written there, inadequate uterine contraction. Regarding the management, we have to give IV oxytocin to stimulate the uterine contraction, and regarding the operative type of management, you have to go for manual removal of the placenta. That means use your hand. Okay, put your hand inside the uterine cavity, catch that placenta and manually remove it. That is the meaning. If it is not possible, if it is a placenta increta or percreta, then sometimes, very rarely, you need to even go for hysterectomy. Hysterectomy means removal of the uterus. Now there are certain test questions at the end. Okay, I will provide this question for your assessment. Just let's do one question, okay, before we go for the break. A 22-year-old woman at term has been 2 centimeters for 3 hours with no change. Normal fetus on sonography, cephalic presentation, and normal electronic fetal monitor tracing. What is the management? So fetus is normal, presentation is normal, okay, ultrasound is normal. She is 22-year-old woman at term, and there is 2 centimeters for 3 hours with no change. Now, what is your management? Now, all of you, please pay attention here. Okay, it is a bit of a difficult question for you at this stage. If you have not listened properly, you can't answer this. So, it is not more than 3 centimeters. So, it is still in the latent phase of the first stage of the labor. So, in latent phase of the first stage of the labor, okay, there is nothing called arrest. It is just, it is still considered normal here. We can wait. We can really wait here. You just wait for the fetal monitoring. Just continue to check what is the uterine contraction. You can check for the maternal status and all those things. You don't need to worry till now.